Okay, so the agenda for tonight is really just to try and get everybody on the same page as far as what is necessary in the lab to make things run smoothly, as well as the doctor side. So I'm planning on going through some scan strategies, tissue management prep design, benefits of digital scanning, and when to potentially use traditional impressions. Okay, so some of the benefits here, of course, are the wow factor. I think most patients prefer to see their scan on the screen rather than having to deal with traditional impressions. So, of course, that's one of the main things here. Second thing is, of course, treatment planning and acceptance. So, if the patients are seeing exactly what's going on the screen and what kicks their mouth, of course, that's going to be hugely beneficial. Less material to stock. You're not going to have to stock nearly as much traditional impression material, of course, because you're scanning things in. You're speeding up the process because you're also sending things in digitally, which takes seconds. And of course, there's less outbound lab mail. Some of the challenges, of course, are barrier to entry. Some of these things can get pretty pricey, although they're coming down pretty drastically lately. The learning curve, if you don't have a great trainer, can be relatively high. If you have a great trainer, then usually this stuff goes pretty smoothly. A lot of the scan strategies we're going to go over tonight are going to show you exactly how to get those good results to make things smoother on the lab side as well as on your side, and to make sure these things are consistent and repeatable. Prepping differences as well. So what to avoid here? Some of the things that I see pretty frequently are something like what we're seeing here, where there's a lot of double scans in here, which is essentially just going over the same area too many times. You can see a lot of scatter there. That's really just scan technique, although some scanners, I won't mention them, have a little bit harder time dealing with this stuff. Some of the newer scanners usually overwrite that and give you better data, but I do still see quite a lot of that scan flash, which can cause some problems on the lab side. Of course, bite issues, like you can see on the top right and the bottom left, we see them wide open sometimes without a bite scan at all. We also see them where they're totally bitten through, so we have to either get a new bite from the doctor, have them rescan, or articulate these by hand, which is of course not ideal. On the bottom right-hand side there is, of course, a margin that is equigingival to the tissue in most scenarios or in most cases there. So that in that scenario, it can be very hard for the lab to see where the margin is. So of course you got to maintain that margin there a little bit differently than you would with traditional impressions, which we'll go over here shortly. Number one rule, like I was just referring to, is you must achieve margin clarity with excellent tissue and fluid control as the mechanical tissue displacement from the impression material is gone. So if you're taking traditional impressions and you're using that impression material in the mouth, of course that tissue is, or that impression material is going to push the tissue or evacuate the tissue away from the margin and give you better margins than you would normally get with traditional impressions or with intraoral scanning impressions. So because of that, you have to go a couple different ways. You have to do something like packing cord, which of course I'm sure most everybody in here is going to be familiar with. Lasers, of course, are great as well. But that also comes down to prep style, eliminating certain lightings, and keeping the teeth as dry as possible. Prep style is really the biggest thing here, of course, other than tissue retraction and making sure that that tissue is out of the way of the margin. If you're using lasers or packing cord and you're evacuating that tissue from around the margin, of course, that margin is going to be very visible, unless the prep style is wrong. If it is a knife edge prep, you're probably still going to have some of those problems. So what you're going to look for here is you're going to look for doing something like chamfers or shoulders in most scenarios. And because of that, you're going to have margins that are very clear. And if you're doing knife edge preps, you can get away with it. I wouldn't necessarily recommend it for most scenarios intraorally. So optimal prep styles for digital scanning, of course, are going to be supragingival, or at least evacuated to the point where you can see the margin clearly. You're going to see a couple good versions of that here in a minute. But as you can see here on the top right, that's pretty much as ideal as you're going to get. On the bottom of that, while you can see that in a color format or PLY, it doesn't necessarily mean that's super clear. And we'll get into that in a minute here. Okay, so chamfers, shoulders. What I mean by softened edges is, of course, in almost every scenario here, labs that get something like this, are going to be producing these digitally, which means they're going to be milling something like zirconia or Emax or something like that. And because of that, you have to take into consideration the fact that there's going to be milling burrs that are milling the insides of those units. And if these things are not rounded over at least a little bit on those incisal edges there, you're going to have situations where the machine itself has to overmill. And because it's overmilling, you're going to get potentially less room occlusally than you might think you actually have. So making sure those things are rounded over just a little bit, making sure you have chamfers and shoulders on there, and making, of course, sure that you have adequate room. That'll make sure these cases go nice and smoothly. Here's a few great margin examples. PLY versus STL. I'm assuming everybody in the chat or anybody on this probably knows what STLs are, but maybe you don't necessarily know what a PLY is. A PLY is a polygon file format. And what I like to tell doctors is to not necessarily use this as a representation of you getting good margins. Because of that, what I really mean by that is you can certainly see what you think is a very clear margin because you're seeing a distinction between the tissue and the tooth. But what you don't realize is when the lab looks at these, they don't necessarily see that nearly as well with the PLY scan versus the STL scan. And the reason for that is lighting and a couple other things. But really what you're looking at when you're looking at a tissue versus tooth graduation there, it really isn't a distinct line. If you zoom in closer and closer, you're seeing that's a graduation between the tooth and the tissue. It's not a perfect line. So what I tell everybody to do is make sure you're looking at the stereolithography file or the STL file to make sure that you're seeing this in that representation, because this is going to be what most labs are going to look at when they're designing. And if you can see the margin clearly in STL format without having to rely on color, generally you're going to get a good result there. So make sure you're toggling back and forth, if your scanning software has that, of course, which most should, between the STL and the PLY to make sure you can see the margin clearly on both of those scans. Here's an example of an excellent scan. As you can see here, tissue is totally out of the way, evacuated very likely with cord there. You can see the margins very clear. Only a couple tiny little areas there where there might be a slight guess. But other than that, this is going to be ideal in most scenarios. Here is the average one. This is something we get. This is probably 70% of the cases we get in the lab where it looks pretty good, but there's certainly some areas in there where they're not ideal. And as you can see there, even though you have color, you can't necessarily tell where that margin is. So making sure you can see the margin in STL format is going to make sure that the lab sees exactly where that margin is so they can proceed accordingly. I have one little question here I might as well ask, or rather answer here. Yes, you can leave those cords in there when scanning, but usually what I see from doctors that have been doing this for quite a long time is they'll pack 2 cords. They'll pack 1 cord in there, and then right before they scan, they'll pull that last cord. So there's one that's sort of keeping things away from the margin. And then by pulling that last cord and then scanning, you're getting very, very nice margins, and they look super gingival, which is ideal. Okay, this is something we get, thankfully not too often anymore, but we will see a lot of these in certain situations where you might have inexperienced doctors, or maybe somebody doesn't quite know how to scan, which is likely due to the training they received. But as you can see here, it's almost entirely a guess. You can sort of see where things are with the STL, or rather the PLY, which is the color scan. But with STL, it's not even as good as the PLY in this scenario. So make sure that if you're sending these through, that the lab is going to be debating on whether or not they should mark margins with either one, and they're probably going to reference them back and forth, which is exactly what you're going to see here. So I gave this to a designer and said, please mark these margins for me and film the screen for me. So this is them totally going in blind using the exact scan you saw a second ago, and this is them trying to mark this margin. Look at the hoops they have to jump through to get this going. This brings another thing up. As you can see here, the lab has lots of tools to find where that margin is. You can see that it's looking at the lowest point on that scan. to sort of figure out exactly where that margin might be. And the reason why I'm bringing that up is because a lot of doctors will sort of take the scan and I've even seen emails of them marking the margins on the screen. And while that's fine, that gives us a good reference point, and I sort of understand why a lot of doctors do that. I've seen that happen for 27 years, where even on like traditional impressions, they'll pour these things up, and you'll see that they request the case back, and then they'll mark the margins and send it back in. While that's fine, and I certainly understand that, I would say that if you have to mark the margins yourself, I wouldn't necessarily do that unless there's something on there that you really want to point out. I say that because the lab has a far larger palette of tools to mark that margin than you might have on your side. They have special software like 3Shape or exocad that can really dial this stuff in, and they can use lots of tools to figure out exactly where that is. So odds are they're going to figure out where that margin is mostly better than an office is going to figure it out, unless there's some really difficult things going on. So if you're doing this and regularly and you're marking the margins, I would say you probably would be better spending your time trying to evacuate the tissue a little bit and getting a little better scans, because you're probably going to, well, most definitely going to get a better result on the lab side because of that. So as you can see here, it took this person maybe 2 minutes to figure out where that margin is, and there's still some questionable areas. As you can see in the lingual side here, potentially this margin's a little bit further up there, but it's not necessarily easy to see these things, and in most scenarios, this is going to end up either coming back as a remake, or they're going to have to call the doctor and ask for a new impression, which is never good. So just make sure that you're sending these things in with evacuated tissue. In any case you could possibly do this, because that's going to speed up the workflow drastically on both ends. You'll get less calls, you get less remakes. Everybody wins, especially the patient. And here is another sort of palette of tools the lab can use to take your scan to the next level, of course. This is going to be a crown design here. You're going to see them use all the tools mentioned earlier to find that margin. And then they're also going to design a crown. And there's a couple reasons why I'm showing this, and you'll see that here shortly. And no, this guy is not super fast. I sped this up about 30%. Looks like I got something from Larry here. More often than not, doctor only scan quadrant scans, opinion quad versus full arch scans. Awesome question. So I like to look at it like this. If it's an implant case, full arch. If it is a single unit posterior, quad. Basically anything outside of a single unit posterior, I'd probably go full arch for multiple reasons. Of course, you're going to be looking at making sure that that bite's correct. And if you do have a full arch scan, you'll be able to make sure that bite is absolutely perfect. With a single unit, not a huge deal. I know we've done a million of them, and of course we get traditional impressions like that as well. And because of that, I think that in almost every case, it's better to have a full arch, but if you're just doing a single quad posterior, perfectly fine. Anything outside of that, including single unit implants, I would go full arch. So this is 3Shape, if you didn't know. You can see they have quite a lot of tools to manipulate the tooth and get things in place. They can see exactly where the occlusion is based on those sort of red lines there. And what this person is doing is manipulating this to make sure everything fits. But they're going to run into a problem, and that problem is room. There's very little room on this case, which you can see there. So they tried to design this with some sort of beautification process with a little bit of anatomy. And as you can see, they couldn't do that because they had to meet a minimum thickness. And the minimum thickness on this, for most scenarios, is going to be something like a millimeter. Certainly the lab can get away with a little bit less than that if they're doing like a very high strength zirconia. I would never recommend it. As you can see on the bottom right, they're using a tool to measure that. They only have 3.5 tenths of a millimeter, so they won't be able to complete this. So this will get all the way through to the design portion. And then they'll have to call in the case, so you might lose a couple days there. So making sure you have enough room with the tools that they have on the software end on your side will make sure that you're not wasting time there too. So certainly look into that, and that usually the reason why you're getting cases back with no anatomy or something that's not very pretty, One of two reasons you're going to get that are they have no room to make any sort of anatomy in there. Secondly, they're trying to replicate what the adjacent teeth look like to make it look a little more natural. So consider that as well. Okay, maybe the most important part of this here is going to be the 3 scanning strategies that I like to go through. I've trained hundreds of doctors on these. I've come up with a few methods myself, which you'll see here in a second. But basically, you're going to get a couple main ones that you're going to see across most brands. This first one here is the standard scan pattern. And this one's going to be occlusion first, which I always recommend. Sort of get your roadmap first. Make sure you're looking down at the occlusion. When you get to the anterior, rock back and forth a little bit on the anterior, go back to the other side's posterior, and then fill in the buccal and lingual side. And there's a couple different ways to fill in that buccal and lingual side. The first one is this standard pattern here. And this one is where you're going to go to either the buccal or lingual side. You can see that I'm actually scanning a model here. And I'm rocking on the anterior to get that incisal third. And then I'm going around to the buccal side. And then right on the anteriors, generally that can be a little difficult to get a nice smooth scan pattern there, which is why in the next scan pattern, which I call the infinity pattern, it's a little bit easier for doctors and assistants to get in there and maneuver the scanner, because you can pretty much keep it in one angle, which is great. So I'm just trying to get those little areas there, just kind of fill in some spots. And as you can see here, there's just a couple little areas where either AI will fill that in, or I can go back in and touch that up. And I think, yeah, I'm going to go back in and touch that one up here, try to fill that in, and then that will disappear. But the light green areas are, in this scenario, this is an electroscanner. The light green there are areas where the software is going to fill those in with AI. So of course, when you're doing this, if you have those little boxes or discolorations that are signifying whether the AI is going to fill it in or not, if they're in a margin, of course, or a contact, please go back in and fill that in, because of course that's going to be the most accurate. You can use AI to fill in those areas in some circumstances, but I would recommend not doing that, especially in important areas. If something like that is on the opposite side of the mouth, of course, that is not pertinent, so you can just let the AI fill that in. But simply go in and just simply fill in the margin area, as well as the contacts, and you should be in good shape there. Usually in most other scenarios, the little AI patches are going to be perfectly fine. This one here is the infinity pattern, and you can see the way this goes. It's exactly the same as the first pattern, rocking on the anterior, going back to the posterior, rolling around to the buccal side here. And then I'm going to go back over to the lingual side. The angle of the scanner does not change in this scenario, so it's pretty easy to get through there. And that makes the whole process significantly faster. So I know folks that can scan arches in 25 seconds with this. On the next scanner, you're going to see it's very similar, but there's maybe it's more error prone. As you can see there, I did that in 25 seconds. And that was me sort of going back and making sure I was filling things in. So just a couple little areas there that I had to let AI fill in. But in general, that's a pretty good scan for 25 seconds. And this is also easier to manipulate when you're scanning in the mouth as well. This one here is the inside out pattern. This one is going to do basically in thirds. You're going to do the lingual side, then you're going to do the occlusion, and then you're going to do the buccal side. And while this can go extremely fast in the right hands, it's also error prone. And I'll show you that on the next slide. Larry, did I answer your question on the quadrant scan thing? So 20 seconds or so to scan this in, and that worked out fine. I'll go back and fill in those areas here. But on the next slide, this is exactly the same scan pattern. And what can happen here, and it can happen in some scenarios, other scenarios as well, but if you're not overlapping the previous scan, maybe 25 or 30%, you can get what's called a double scan. And I see that most, yes, I can certainly go back and do that. What I see most here is I'll show this quickly, and then I'll go right back to that infinity scan for the person asking. So in this scenario here, you're going to see that I was not overlapping quite enough because it was difficult to get it. And then you'll see a significant double scan and a couple teeth here. and you'll see why. Everything's exactly as you'd expect. And then when I'm going back to touch this up, I sort of get into a position where I'm hovering in space too much right here. And then you'll see that it's giving me a double scan there. And that's really because I was not overlapping the previous data, which sort of grounds the scan. So as you can see here, real obvious double scan. And I see these all the time, unfortunately. But the reason for that is your scanner is not able to tie together the previous scan with the new additions. So you can overcome that by simply going back and making sure you're overlapping the previous data by 25 or 30%. Let me go back to the infinity pattern and show you that one again. Little rock on the anterior. That's just to get the incisal third. So when you're scanning the buccal side, it's easier to tie in and you're not getting into a situation where you might get double scans. Top left shows the time. Probably got 25 seconds, I think this was. Was that okay? Great. Okay, we saw the double scan here. So another thing we should talk about is not all scanners are created equal, of course. Proper scan strategies will vary per system, like I mentioned earlier. Following manufacturing guidelines will certainly provide better results. But even in those scenarios, if you don't get proper training, you potentially could have some issues. This is the big one too. Watching the screen rather than the mouth will yield better results with practice. And the reason for that is if you're looking inside the mouth, you don't necessarily know exactly where that scanner is in the mouth. You have a pretty good idea, but if you're looking at the screen, you can tell exactly where that is. What I see when doctors are not looking at the screen and rather looking in the mouth when they're scanning, that's when you'll see the most double scans, and the issues with the scans is because they're not overlapping quite enough. So following the screen will allow you to overlap just enough to eliminate some of those errors. So choosing the right intraoral scanning system, there's a few examples there, but I think what it's going to come down to is sort of what you jibe with the best. There's a lot of these systems, let's say Trios or Itero or Electra or Sirona. All those softwares are different, and the analogy I like to make is some folks are Mac guys, some folks are PC guys. You can't convince the PC guys without threat of bodily harm that the Mac is better and vice versa. You cannot convince these folks to do it. It's the same with these scanners. In most scenarios, a doctor will prefer something like a Trios or Electra or Itero, and then the next doctor next door might prefer something totally different. And it's because of the way the software works. Sometimes it's intuitive for somebody, sometimes it's not intuitive for the next person. So make sure that you're at least trialing these out, or you see a good demo online that's showing you the software and the workflows within this. Secondarily, if you use something like Medit, which is a great scanner in its own right, it is very advanced on the back end because you can install a million apps, and you can even do some design with that software. So in some scenarios, that is great for folks that are liking to do things in their office. And other scenarios, it can be very overwhelming on the screen, and you might not want any of that information. So you might purchase something like a Medit based on the good reputation, and then get to a point where the scan software itself is a little bit too confusing simply because there's so many options on the screen. So in that scenario, certainly make sure you're checking out multiple systems. Make sure you're getting something that is future-proof in most regards. Make sure you're not going overkill. Like you don't need a million features when you're scanning single posterior crowns. So you can, go with a cheaper scanner set in that scenario. But really, what you want to look at is what fits in your office workflows the best. Anonymous attendee, yes, you can. I think that Catapult is going to provide that at the end of this. Okay, so having said that, all of these scanners are clinically acceptable. You're not going to buy one of these scanners and it's not going to give you good results. They can all give you good results. Even the super cheap ones will give you great results. The difference maker is the training. So if you're not getting good training and you're not shown exactly how to use these things and how to work them in your office, then that's when you get into situations where you're getting bad data. So if you're getting something like a Medit and you weren't trained properly, or you get a Sirona and you get overwhelmed by the software and it's simply not intuitive, and you're scanning and you're going over things a million times to try and fill in data, that can get overwhelming, and because of that, you're not going to get good scans. I've seen folks, because the time is on the screen when I'm logging into some doctor's offices, where somebody might be scanning in the mouth for 5 minutes or 6 minutes, when you really should be somewhere sub 1 minute. So training is the difference maker there. If you're not getting good training from the manufacturer, I'd probably recommend not going with that manufacturer. So if you have a good discussion with them, you tend to like the software, but their training is not up to par, then I'd probably go a different route, simply because that training is absolutely key to getting good results. So make sure you're at least talking to that rep, get what that training schedule is. If it's not at least a few hours and potentially even in person, then I'd probably eliminate that from the pool of scanners to choose from. Okay, best practices review. Of course, tissue and fluid maintenance is the number one thing here. So if you're scanning these in and you don't have good tissue or fluid maintenance, you're not going to get good results. You're at least going to get subpar results, and nobody wants subpar results. I know we have a lot of important people in this call, so I would anticipate that nobody in this call or in this Zoom meeting wants to get subpar results. Everybody here wants to get excellent results. So the way to do that is making sure that you have good tissue and fluid maintenance. The scanner cannot determine what is tooth, tissue, or fluid. So if you have a pool of fluid on a prep, it's going to scan right above the margin. You won't even know it. It'll look to the end lab like everything is perfectly fine. And then you might get something like a short margin that is 0.3 of a millimeter off or something. In a lot of those scenarios, it's scanning the fluid. So make sure that you're doing excellent fluid maintenance and tissue maintenance to expose that margin. Chamfer or shoulder preps, of course, are absolutely key as well, especially in the digital age where labs are making sure that they're doing these things digitally. If they are completing these things digitally and you don't have chamfer or shoulder preps, keep in mind they cannot remove tissue or guesstimate in most cases where that margin is, like you can with traditional impressions. So I was a STL and POY. I'll tell you that in 1 second. I was a model tech 27 years ago for several years, so I got to see exactly how this worked throughout time. And I'm sure everybody here knows that if you're doing a traditional impression and there are certain areas where you think that the tissue is covering the margin, you can remove that and then mark the margin in there. While you can do that digitally, in my opinion, it's not quite as good as traditional impressions. So if you're not able to get a good traditional, or rather intraoral scan, I'd probably move to an impression, simply because there's probably a few reasons why you're not able to get it. It could be the patient, it could be lighting situation, it could be training. I wouldn't wait too long with that. If you're scanning and not getting good results, simply do a traditional impression and send that in like the normal way you used to do it. But in most scenarios, if you're doing good chamfers or shoulders and good tissue maintenance, then you shouldn't have that problem. Another key point here is direct light. If you have a direct light on a lot of these scanners, or on the teeth rather, that highlighting on the teeth can make it so it can't quite scan the prep, and you'll get situations where you might have some scatter on that tooth because of that, or potentially even some distortions. So making sure there's no headlamp, no direct lights. These scanners have lights in them. They're built for that. So make sure that you're scanning with very low lights or just ambient light in the room. No need for headlamps, no need for direct overhead lights. And in most scenarios, those are going to cause more harm than good. Proper scan paths like we went over, and then of course, excellent training and support. Do gold crowns on number 2 or number 15 make it hard to scan the distal for ortho? Yes, but some scanners can overcome that. There's for example, Medit and Electra both have a certain lighting format that you can switch back and forth. So in Medit, there's a metal icon in there where you can click that, and it'll allow you to scan those teeth a lot better. On Electra, you can certainly slide that lighting slider down, and you'll be able to get a little better scans that way. But you can usually overcome this. I hesitate to say this because it's not always true, but you can usually overcome this if you back away from the tooth a little bit. That way, the light from the scanner itself is not sort of overwhelming the screen itself. So just pull back the scanner a little bit. That lessens the light, and then usually you can capture that. If you're not able to capture that, and you're going with an ortho case that requires those areas, that's another scenario where you might want to consider using traditional impression. Okay, I'm not sure I want to go into this quite yet, but I think this is a good time for Q&A. I know I've had a few questions here, and it goes relatively fast when we don't have questions along the way. But this just opens it up for we can do probably another 20 or 30 minutes of questions and answers if you need to. Oh, STL and PLY. STL is basically a monochromatic file, and that file is usually preferred by the lab. They can use, there's in the scanning, or rather in the design software, there is a specific type of light that is much easier to see on the STL than on the PLY. The PLY is slightly more realistic, of course, because it's color, but because of that, those graduations or changes in color make it harder to see that margin. So using the light in a certain way with a monochromatic file, as is the STL, which is the monochromatic file, it's easier to make those decisions. How many times will it take a regular scanning? Taking too long automatically stops the scanning and you have to go all over again. Usually that's not the case, but if you are having problems, I'd probably not continue with that scan. If you are doing that scan and you're not able to complete that, I'd probably just start over. But usually that happens because you either have some tissue maintenance issues, or you have some highlighting because of an overly there's too much fluid in the mouth or something, or there's too much light. But regular scanning, and most scanners these days are sub 90 seconds for an arch. So you should be able to complete the entire thing in easily under 5 minutes. If it's taking over 5 minutes, usually that's the cases that are a little more difficult. That's the cases where you're having some reach issues potentially with the scanner. But usually that's simply because you have some issues with the scanner itself and potentially the patient themselves as well. How do you scan a case for full mouth preps to capture the bite registration? I knew that was going to come up. That's a tough one. So in those scenarios, like I've seen folks do wax bites or wax rims, and then they scan the wax rim in place to do those. I've seen folks use like tensing systems to put the patient in proper sort of natural occlusion without the teeth there. But usually that's the hardest ones. But what are some of those ones are certainly the hardest ones because of that. And I've also seen folks just simply send in scans of the dentures after the fact. So you can use that intaglio and cameo data, or the intaglio data from both arches rather, to position those bites. I hope that answered that. What are some of the features and advantages of the Electra scanner? I'll just go right back to that. How about that? It is the smallest and lightest in the market, although I think Trios is catching up. It's very, very close there now. Scan time is super fast. These things capture extra fast. So we're doing 20 to 45 seconds per arch pretty routinely. I have sales reps that are out in the field that have learned this from me, and they're scanning regularly under 30 seconds. Training on this is very fast. Pricing super cheap too, as far as what it is in the market. It's not as full featured, so you're not going to be using this for something like scanning the intaglio and cameo data of like a denture or something. But you can certainly use this to do all your crown and bridge and implants, no problem there. And it also is just as accurate as pretty much everything in the market. So you're looking at 7 micron accuracy. How do I like the iTero or rate the iTero? The iTero it's awesome, industry standard. Nobody has more scans out there. It's very clearly a market leader. So there's nothing bad there at all to say. I think that scanning system is robust, and I think it's tried and true. I will say that one of the things that I'm not fond of on that system, and I assume at some point this is going to go away, but I think that the Achilles heel for that system is they train on the fact that the iTero system or the iTero team in a different country can take your scans and clean them up a little bit before sending them to the lab. So the lab gets a little more clearer scan. But because of that, they're using that data, which has been altered, and you can get some situations on the lab side where that data or that manipulation of that scan is not perfect. So of course, if they're trained properly and the doctors are not necessarily relying on the iTero team to sort of correct those scans that are not quite right, it's a great scanner. Of course, the workflow is great, no problems there. I will say that there's on the lab side, there is a setting where you can have doctors send directly to the lab, and this is determinant on the lab side. So the doctors can either send directly to the lab, or they can send directly to iTero for cleanup. But the problem is if the lab side says, I want to get all these files from the doctors raw as fast as they send them, because there is a cleanup, doctors sort of use that as a crutch, unfortunately, and they'll send these files through, and then the lab side has to do the cleanup, and they don't have the same tools that iTero does. So that's something to consider there. So if you're going to use the iTero system, awesome system, great support. Scanners are some of the best in the market. Make sure you get great training. Make sure you don't rely on the iTero team. Okay, I hope that answered that. What about Trios and soft tissue scanners? What model is best for edentulous cases? Great question. Trios is top of the food chain as far as feature set. They are, in my opinion, probably the most future-proof because they're just constantly evolving that software, and they also know the lab side extremely well because the 3Shape software is ubiquitous in the industry. Virtually every lab that is designing crowns has 3Shape. If not, it's going to be exocad. And they're compatible with both, of course. So the Trio system has direct to lab sending. So as soon as the doctor's done sending, it goes directly to the lab. The lab has a queue. They can work on those cases immediately. And then they can case enter the case in parallel to that. So they can move these things very quickly. So that's a good system. Feature set is very robust, has no problem scanning edentulous cases. And in fact, most new scanners don't have too much of a problem scanning edentulous cases. But if you do have a situation where the tissue is a little bit too smooth or the rugae is potentially too smoothed out, you can put a little bit of flowable in there, like a little wiggle of flowable in there, cure it gently in there, and then make sure you don't touch it. But if you're scanning the little squiggle in there, that little squiggle of flowable in there, sorry, that's not the technical term. I'm not sure what to call that, but that helps tie everything together. So if you have a very smooth tissue or tissue that is not giving you good results as far as trying to sort of tie things together, then you can do a few little things to get that to tie together properly. You can even put little buttons in there, various things to sort of create your own landmarks. The lab side can easily remove. Okay. Future-proof and open source scanners. I think in most scenarios, the open situation or the open scanners are going to be the best bet. And I don't say that lightly. I've worked with all these scanners, and I've probably personally seen over 100,000 scans from virtually every company out there. And I'll tell you that you can get great results from all of them, like I said. But as far as open source scanners, I was struggling with Sharona for quite a long time to have them sort of open things up and send to labs rather than keeping it all in one little what do you call it, ecosystem. Because of that, it was difficult to work with them for quite a long time. Now everything's sort of open. They've moved over to DS Core, which if you're not aware and you do have a Sharona scanner currently, they're going to switch to DS Core online only, I think in Q1 or potentially even January. So we're like a month away from them switching entirely away from the previous portal. This is maybe the third or fourth portal change over the last few years. So make sure that if you're using that system, look into DS Core. You probably got spammed with emails from them about that, but look into that surely. But anyway, having an open system is usually the best case scenario because in most labs are going to use raw files. They're not going to even use a Sharona system. And in most scenarios, with Itero, Itero can send in raw files, no problem. So that's a 75% open system, but they also work directly with Exocad. So that system there is great. But as far as the Trio system, it does not necessarily have to work with 3Shape. So that's also almost completely open. But pretty much everything else out there is totally open, and they're giving you standard STL files. So I think the best way to future-proof your office is probably to get on a system that will at least allow you to communicate with the lab without having to worry about using an ecosystem that might change drastically over time because they're upgrading things or changing a portal or something like that. So make sure that you're getting into a system that does have that open scanner where you can at very least export out STL files that you can send directly to the lab. But yeah, that's probably the best way to do it, is to attempt to get away from an ecosystem that ties you together to one sort of thing. So Medit, Medit scanner, the 900, I've not personally used that, but I did use the 700 wireless and the 500 and the 700 standard for quite a long time. I even trained on that system and I was certified on it. I think that it's getting only better over time. Their system is getting more and more robust. I think a lot of the upgrades that they're putting in there are key to making their ecosystem work. So I think that 900 is a great option. Potentially, that's one of those systems that you might get into and be overwhelmed due to option paralysis. But if you're sort of a geeky doctor that loves to do a lot of things themselves, potentially even design or printing in office, then the 900 is an awesome option, and you can do virtually everything you want there. So you can go in and design things. You can even go in to do certain ortho cases with that, with all the apps that are included or downloadable for free. So yeah, that is a very robust system, wide-ranging, million options, potentially overwhelming for a portion of the audience. But it's a great system, surely. Of course, thank you for that clinical hack. RA tissue management, of course, my pleasure. Is there a particular Trios or 3Shape model that is the best? I'm not sure what you mean by model. You could reiterate that. How many times will it take? So thank you. 7 accuracy. That's right. You're right. Mr. Jacob, you're absolutely right. That's resolution. I want to scanning oral applications for sleep. What's the cheapest available? I'm in Canada. Thank you very much. Canada, so it's significantly more expensive out there, and I get it. Geez, that's a tough one. There's a lot of things out there that can do those cases. So potentially the cheaper Trios is great for that. Medit's certainly great for that. Itero can do that. The one thing that I worry about older Itero scanners for doing these the bigger denture cases is the scan depth is about 15 millimeters, and because of that, sometimes you can't get like vaulted pallets. It's hard to get in there. So make sure that you're getting a scanner that has that. So I'd probably point you in the direction of something like the cheaper Trios. Although we sell Electra and it's certainly capable of that, that's not really its forte. You can do it, but that's not its forte. Just totally upfront and honest. I think that the Electra scanner is something where you're going to get that for mostly crown bridge and implant cases, not necessarily for the big full arch cosmetic cases or all on X or something. But Trios, Itero, Medits, all those are perfectly fine for that. And I think probably like the Trios system might be cheaper with some of their options. So look into that one. Okay, is there a limitation in marginal depth that the Itero can read? That's funny because I just answered that. Perfect. That's 15 millimeters, although the newer ones probably are deeper than that. I'm familiar with 6 months ago or a year ago. Medit 900, we just did that. Yes, it could certainly be used for edentulous arches. I think we're all good there. Oh, Trios Core versus Trios 5. Trios Core, I'm actually not entirely familiar with the Trios Core. I know they've changed the names a lot, but Trios 5, I've actually personally used to train in some offices previously, and that is an excellent scanning system. One of the best, if not the best on the market. So the Trios 5, very small form factor, software is very robust, easy to scan with, great option there. I think I got through all those. That was awesome getting a bunch of questions. I love it. First of all, this is me. I'm in Nashville currently, so I'm on Central Time. This is my email here, so if you have any questions after this scenario or after the webinar here, feel free to email me at any time. I'm glad to help. I have been doing this for a long, long time. 27 years, coming up on 28 years in January. Started off in the model room and went all the way through the initial stages of digital design. In fact, one of my mentors is in the chat here. I'm sure he's going to blow me up at some point, but yeah, we worked together for a very long time. He's now a KOL, awesome guy. But he is somebody that got me started on this thing a long time ago, probably 22 years ago. I've been doing digital stuff. So I can pretty much answer any questions all the way from model room, all the way through the entire lab, all the way through digital design and manufacturing and intraoral scanning. So any of those questions you might have, send them my way.